Welcome back to the deep dive. Today, we are getting highly technical. We are scrubbing in on a procedure that, frankly, has a bit of a reputation problem in breast reconstruction. We are talking about the Latissimus Dorsi flap.
The LDF.
Right.
The workhorse, or, as I hear it described in the surgeon's lounge all the time, the lifeboat.
The lifeboat, exactly. It is usually viewed as that distant third option. You know the drill.
Yeah.
If you cannot do a DEP or a tram because the abdominal tissue just is not there, and you cannot do a simple implant because the skin envelope is shot.
Then, and only then, do you call in the latissimus.
Right.
That is the historical stigma. It is seen as a salvage operation, just slapping a muscle patch on a defect to close a hole.
But what we are analyzing today challenges that framing entirely. We are looking at a technique that takes the LDF from a backup plan to a primary aesthetic tool.
Yeah, this is not your old school muscle-only flap.
No, we are diving into the volume-added concept. It is a specific way of harvesting and insetting that essentially mimics an autologous flap, but it has the reliability of a pedicled muscle. Our mission today is to walk through the operative strategy, from the marker to the final suture, specifically for the plastic surgeon who wants to elevate their game here.
And the devil is absolutely in the details with this one. I mean, the difference between a lifeboat result, which just looks like a patch, and a superior aesthetic result comes down to things like the zone of adherence, the precise layer of fat harvest, and how you handle that nerve.
So let us start where every good operation starts, the marking pen. Before we even get the patient to the OR, we are standing them up. What exactly are we looking for?
Well, you need your boundaries. Standard anatomy refresher here, but it matters. You have got the midline of the back, the tip of the scapula, the posterior border of the axilla, and the iliac crest. Those are your hard stops.
Right.
But the relationship you really need to watch, and where I actually see a lot of residents get confused, is the inferior trapezius.
It overlaps.
Correct. The trapezius overlaps the upper medial border of the latissimus. It is a trap, pun intended, of course. You have to mark that out so you do not get lost in the wrong plane later. If you dissect too high, you are in the trap, not the lat. But the real art here, I think, is the skin island.
This is where I feel a lot of people get tripped up. The textbook often just shows an ellipse. You do not just draw a circle in the middle of the back.
No, absolutely not. Ideally, you want that skin island centered over the muscle to ensure you have equal muscle coverage on all sides once you inset it. But the orientation is critical. You have to follow the relaxed skin tension lines, the RSTL.
Which on the back is not a straight horizontal line.
It is not. It sweeps. It generally goes from supromedial, high up near the spine, curving down to inferolateral toward the flank. If you orient your ellipse along that line, the scar settles beautifully.
And if you go transverse?
If you cut straight across those tension lines, you are asking for a wide, hypertrophic scar, and patients hate that. You cannot hide it under a bra strap.
So you are angling that ellipse to follow the natural drape of the back skin. Now, there is a specific danger zone we need to cover, the zone of adherence. This sounds like something out of a sci-fi movie, but clinically, it is a huge deal.
It is the single most critical landmark to respect if you care about the final breast shape. This zone is the upper anterior border of the muscle and the lateral border of the breast.
And the instruction is simple. Do not dissect there.
Hands off. Keep that attachment completely intact. And here's why. That adherence defines the lateral breast contour. If you blow through that plane while you are dissecting, or maybe you are trying to make your tunnel too wide, you disconnect the skin from the deep fascia. You instantly lose that definition.
But I mean, in real life, cannot you just fix that later? Throw in some deep sutures to recreate the fold.
You can try, but it never looks right. Here's the clinical pearl. You really cannot recreate that lateral definition with sutures once you have blown it out. Once it is gone, it is gone. You end up with a breast that just sort of smears into the armpit. It looks amorphous.
That is a nightmare to fix. So we respect the zone of adherence. We mark our tunnel high in the axillary to avoid messing up the lateral chest wall. Now, let us move into the OR, patient positioning.
Ah, the great debate. Lateral decubitus versus prone. A lot of surgeons like lateral because you can prep the chest and the back at the exact same time. It is about efficiency, right? But for this specific high-precision harvest, you really should be in the prone position.
Face down. Why is that non-negotiable for this particular technique?
It stabilizes the anatomy. When you put a patient in lateral decubitus, gravity shifts absolutely everything. The breast falls medially, the back skin slides down, your landmarks distort. When they're prone, the scapula, the spine, the iliac crest, they're exactly where they should be. You can see exactly what you are doing.
Okay, so we are prone. We have made our incision. Now we get to the core concept of this entire deep dive, the volume-added latissimus. Because this is not just taking the muscle and the skin paddle.
Right. The old school way was just muscle and skin. The volume-added technique is about harvesting the deep layer of subcutaneous fat well beyond the skin island.
So you are extending your harvest radius into the fat layer. Walk us through those dissection steps.
You incise the skin island, but instead of cutting straight down to the muscle at the skin edge, you bevel out. You find the deep thoracic fascia, that is your carpet carrier. You divide that fascia and you dissect under it.
So fascia stays with the fat.
Exactly. By staying deep to the fascia, you carry that vascularized fat pad that sits on top of the muscle, and you carry it well past the borders of your skin incision. You can grab an extra 2, 3, even 4 centimeters of fat radius.
That is the key. You are bringing extra bulk that is not skin.
And that bulk is what softens the mastectomy edges. It is what fills the defect. It turns a thin muscle flap into a highly substantial soft tissue flap. You peel that whole complex off the back, you release it from the trap, release from the iliac crest, release from the serratus.
Speaking of the serratus, let us talk vascular safety. The thoracodorsal pedicle is obviously the lifeline. But let us be real here. General surgeons can get pretty aggressive during the lymph node dissection. What if the pedicle is compromised?
It happens, and it is a heart-sink moment if you do not know your anatomy. But the LDF has a backup generator, the serratus branch.
Explain the flow dynamics there.
There is retrograde flow. If the main thoracodorsal artery is cut proximally, blood can flow up from the serratus branch and keep the entire latissimus alive.
So the practical operative takeaway is do not cut the serratus branch unless you absolutely have to.
Precisely. Check your pedicle first. If the main flow is bounding, sure, you can divide the serratus branch to get more arc of rotation. But if there is any doubt, literally any suspicion that the main vessel was nicked, you preserve that serratus branch. It is your ultimate safety net.
Good to know. Now, here is a massive point of contention in the plastic surgery world. The nerve, the thoracodorsal nerve. Do we spare it or do we cut it?
In this technique, you cut it.
Snip. But wait, let me play devil's advocate here for a second.
Yeah.
We just spent 10 minutes talking about volume added. That nerve keeps the muscle bulky. If you cut the nerve, the muscle atrophies. Do we not lose the volume we just worked so hard to harvest?
That is the classic argument, right? Save the nerve, save the bulk. But clinical experience shows the atrophy is aesthetically negligible. You lose some thickness, yes, but you keep the surface area and, more importantly, that thick fat pad.
So the volume loss is not catastrophic. What is the upside of cutting it then?
Patient satisfaction, period. If you leave that nerve intact, the muscle works. It contracts. Every single time that woman moves her arm, puts on a seatbelt, or reaches for a coffee cup, her breast jumps. It is called animation deformity.
Which can be incredibly distressing for the patient.
It is miserable. It feels completely unnatural. It feels like an alien object on the chest. By dividing the nerve, you eliminate that animation. You get a static, soft breast. The trade-off, losing a tiny bit of muscle volume versus having a breast that jumps every time you move, is absolutely worth it.
Cut the nerve. Got it. So we have harvested our volume-added flap. We've managed the pedicle. We're ready to flip the patient back over and inset this thing. We are passing it through that high axillary tunnel.
And remember, tight tunnel. You want that opening to be only about 2 to 3 centimeters. Just enough to get the flap through.
What happens if it is too wide?
If you make it too big, your implant or expander can migrate back into the axilla or even onto the back. You do not want to be fishing an expander out of the patient's back 3 weeks post-op.
That is a visual I did not need. Let's talk about the inset. If it is a small breast, it seems pretty straightforward, just suture to the mastectomy margins. But what if we're dealing with a large defect? The latissimus is a big muscle, but it is not infinite.
This is where you use the vest overpants technique.
I love that name. Describe the mechanics for us.
If the defect is large, you release the pectoralis major muscle anteriorly. The pec retracts upward and covers the upper pole of the implant. You bring the latissimus in to cover the lower pole. Where they meet in the middle, the latissimus goes over the pectoralis. Vest over pants.
So you are double layering the coverage in the center.
Exactly. You avoid that window shading effect where the implant peeks through between the muscles. And this is crucial for the volume-added goal. You are creating a completely enclosed soft tissue envelope that isolates the implant from the skin. That is how you get that natural feel and avoid that shrink-wrap look.
Before we close the hood on stage 1, we have to talk about the donor site, the back. This area is notorious for seromas. It is seroma city.
It is the #1 complication by far. You have created a massive dead space on the back. The strategy here is aggressive management. You use quilting sutures. You are literally tacking the Back skin flaps down to the underlying intercostal muscles to physically close off that dead space.
And drains.
Drains are totally non-negotiable, and you have to prep the patient for this in clinic beforehand. Those drains might stay in for up to 6 weeks. You do not pull them until the output drops significantly. If you pull them early, you will be aspirating seromas in the clinic for months.
Okay, let us zoom out to the philosophy of the reconstruction itself. We have got our flap inset. Now, do we put in a permanent implant right then and there, or do we use a tissue expander?
Well, many surgeons would say, hey, the skin is preserved, just put the final implant in, one and done.
It is tempting.
Yeah.
Patients certainly prefer one surgery over two.
It is very tempting. But the preferred strategy here is to use a tissue expander at stage 1 regardless. But, and this is the vital nuance, you do not treat it as an expander, you treat it as an intelligently chosen spacer.
An intelligent spacer. Unpack that for us.
Think about the physiology of what you just did. You have done a major dissection. The tissues are swollen, they're angry, they're trying to heal. If you shove a permanent implant in there, you are guessing at the final size and shape. You are committing to a volume while the patient is highly inflamed.
So the expander just holds the door open.
It holds the pocket open. It lets the soft tissue heal and settle around a shape without tension. It allows you to control the footprint. Then, when everything is calm, usually 4 to 6 months later, you come back for stage 2.
It turns the reconstruction into a bespoke tailoring process rather than a guessing game on the table.
Exactly. And honestly, it takes the pressure off stage 1. You do not have to be absolutely perfect on day 1. You just need a healthy, well-perfused pocket.
So let's flash forward those 4 to 6 months. We are at stage 2. We are swapping the spacer for the permanent implant. What else are we doing?
Nipple reconstruction. And this is where the LDF shines again. If you used a skin island from the back, that back dermis is exceptionally thick. It is much thicker than native chest skin.
Why does the dermis thickness matter so much for a reconstructed nipple?
Memory and projection. If you make a nipple out of thin chest skin, it tends to flatten out over time due to bra pressure. It collapses. But a nipple made from the modified skate flap on that thick back skin, it maintains projection. It stays perky.
That is a huge aesthetic win. Stage 2 is also the time for cleanup, right? Liposuction.
Usually lateral chest wall. Remember that tight tunnel we made? Sometimes the muscle bulk there can leave a bit of a dog ear or a bulge under the arm as it turns the corner. Stage 2 is the perfect time to lipo that down, refine the inframammary fold, maybe adjust the opposite breast for symmetry. It is the polish procedure.
It really emphasizes that breast reconstruction is a process, not a single event. I want to circle back to something we touched on regarding the immediate reconstruction. If you are doing this at the same time as mastectomy and you are using the skin island, where exactly does that scar go?
That is the puzzle. If you can, you want to bury that lower scar in the inframammary fold. Hide it underneath. But you have to be very careful.
Specifically regarding the blood supply of the skin between the incisions.
Right, the crisscross. If you have a mastectomy scar going horizontal, and you cut a new line for the flap inset going vertical, you create these triangular islands of native skin between the scars. Those islands have incredibly precarious blood supply.
They turn necrotic.
Often, yes. So sometimes, if the geometry is tricky, you might just open the original mastectomy incision and inset the flap right there. Yes, you have a patch of skin on the breast that does not perfectly match the color or texture of the chest skin. Back skin is often a bit lighter, but it is safe.
And we really need to mention smokers here. We talked about how robust the muscle is, but the skin on the back is a different story.
Proceed with extreme caution. The LDF muscle has a great blood supply, but the skin at the donor site on the back relies heavily on the perforators coming through that fat. If you undermine too aggressively to get your volume-added fat and the patient is a heavy smoker, the back skin flaps will die.
So in smokers, you compromise on the fat harvest.
You have to be less aggressive. You leave more fat on the back flaps to ensure they survive. It means slightly less volume for the breast, but you avoid a massive wound dehiscence on the back.
So, bringing this all together, we started by saying the latissimus is often seen as the distant third option. But after walking through this volume-added technique, the expander as spacer philosophy, it feels like we are selling it short by calling it a backup.
I think we absolutely are. If you look at the results, especially in bilateral cases where a woman simply cannot spare abdominal tissue, this technique offers a breast that feels like autologous tissue. It is soft, It is warm. It has that natural drape because of the fat we harvested.
And compared to a DEP flap,
It does not have the risk of total flap loss. You do not have microsurgery failure hanging over your head. It is incredibly reliable. And with the nerve cut, it does not animate. So you have a static, soft, natural-feeling breast.
but there is a cost. We cannot gloss over it.
The scar, there's no getting around it. You're putting a large scar on the patient's back.
And that leads us to the final thought for our listeners today.
It comes down to a trade-off. And it is a frank conversation you have to have with the patient in clinic. You ask them, is the price of a scar on the back, which can usually be hidden under a bra strap or a bathing suit, is that a fair price to pay for a breast that actually feels like real tissue?
Versus a simple implant reconstruction that leaves the back untouched but might feel firm, cold, or have visible rippling.
Exactly. For the right patient, someone who prioritizes the feel and the natural aesthetic of the breast over the presence of a back scar, the volume-added latissimus is not a lifeboat. It is the luxury yacht. It is a premium choice. But you have to execute it with the precision we talked about today. Respect the zone of adherence. Harvest the deep fat. Cut the nerve. Use the spacer.
That is the game plan. As always, the difference is in the details. Thanks for scrubbing in with us on this deep dive. Think about that trade-off next time you are evaluating a patient with a compromised envelope. We will catch you on the next one.
See you in the OR.